with respect to this topic, so I would encourage the delegates to speak with Dr. Gomez or Dr. Gurka. In particular, if they're considering his one-stage technique, because there are some very important technical aspects, I think. You're really doing two surgeries in the same setting. And I think that needs to be highlighted. This is not just taking the stuff out and putting a new one in. I think there are some very important technical aspects to the way they've achieved that, and I congratulate you on your success. So I'm going to talk about the two-stage management.
Para aprovechar un poco el tiempo, no sé si alguien tiene alguna pregunta de las charlas previas. Doctor Gómez, usualmente los espaciadores vemos que la gran mayoría tienen que tener... después
So two-stage management. And again, this relies on some fairly basic concepts of timely diagnosis. I think identifying the offending organism is a significant advantage for us. I do think there's a component retention considered in selected early cases, but my task today is to discuss a two-stage reconstruction. IND, and again, the consensus delegates, 80% agreed that there were selected cases. I wanted to present one issue one of our colleagues has brought up down at Mayo Clinic in Scottsdale, and that's Henry Clark and Mark Spengel, and their work on, in fact, doing a two-stage debridement with component retention. So it may be, in fact, that it's not just two-stage surgery that we're doing for the two-stage exchanges, but also a two-stage irrigation, debridement, and component retention. So stay tuned for that. This is June 2019 publication on their specific techniques. So why do a two-stage? I think a reimplantation should be carried out with the advanced knowledge that if it fails, you're in big trouble. Why do we fail? Must be the biofilm. So biofilm is secreted within 6 to 12 hours. You've got a mature biofilm colony that's able to shed bacteria within 2 to 4 days. So although we often state on the podium that a few weeks of symptoms still allows us to do a retention, I think the biology is not quite as supportive. There's no question that there's some debate about the success rate and the subsequent success of a two-stage revision, but if you're considering an IND, depending on how you select your patients, you may be paying a cost down the road with a two-stage revision. And some of the work out of Rafa's center at Mayo Clinic, this is going down back a few years, but if you had a reinfection or a second infection, the results are quite devastating. You can see resection, arthroplasty in the majority, chronic suppression, and successful reimplantation was rare. So this is the original consensus. 93% were supportive of a two-stage revision. You want to prepare the patient well. We like them off all antibiotics a minimum 2 weeks, longer if you can. Optimize their nutrition, so look after the overall host health. Manage their diabetes if you can, get them in line. Anticipate soft tissue problems, so plastic surgery evaluation can be effective in the very few cases. A nice award-winning paper. When you get them into the OR and they're under anesthesia, give them the antibiotic that you would routinely. You may be able to actually direct the antibiotic if you've done an appropriate aspiration and obtained a positive culture to that bacteria, and that should not affect your cultures at the time of surgery. Removing the sinus tract is obviously important. Removal of the prosthesis and cement. We have a lot of long uncemented stems in North America, so we do have to do a few more ETOs. I agree with you that with the blade stem, which is commonly used, I can get those out from the top. Intraoperative radiographs are an effective tool for making sure you've removed all of the cement. You can often see it. Cement restrictors, cables, wires, and anything that is foreign or decayed in the area. So you do really want to be very aggressive. An odd number of cultures are helpful. When I arrived at the hospital, the world-famous hospital for joint disease, they were still routinely just doing swabs. I would strongly encourage you to take proper samples of soft tissue. This is very important for obtaining a diagnosis. I use high-dose antibiotics in cement. You can see the trays that they put together on the back table. I use sterile mineral oil to make these mobile spacers. I often assemble it prior to starting the revision. So I use a Prostalac. I have no conflicts with this company. I just find it's the best one in my hands. And I'll actually open the longest bowed stem because I think it gives me more surface area for leaching of the antibiotics, and I'll make it before I even start the case. So again, long ETOs, I use 16 or 18 gauge wires. I do a figure of 8 approximately around the abductors. Almost always use the longest head size, and that's because these smaller cups, when you cement them, they're a little more proximal, so you can get much better soft tissue tension with the longest head. And I use a collar of cement to reduce subsidence and rotation. In the rare case where you've got significant bone loss in the acetabulum, you can actually cement in 2 different steps. I still put in that snap fit, semi-constrained acetabular component. If you look at the outcomes, again from Mayo, 135 2 stages with the Prostalac system, 12% reinfection at 5 years, but they had a 10% dislocation rate. So again, dislocation is a significant issue when there's soft tissue compromise around these cases. I'd suggest that perhaps a dual mobility in the future at the second stage could reduce that risk of infection. These are my mobile spacers I use for a typical knee. I put dowels up and down the canals. Mike Meneghini has published a recent study suggesting that the dowels might not be necessary in all cases. I think the leaching of antibiotics and previous work demonstrating the 25 to 30% infection rate of the canals that gets us irrigating, debriding, and placing these in the canal. So I think that's an effective tool. And here's how I make them. I drill up into an all poly on the tibial side, and that gives me a remarkably secure fixation. I was somewhat nervous when I first did these. The consensus suggests mobile when you're able to. Dislocations, I thought this was an interesting consensus result. This is with respect to the spacers. Dislocation does not mean you should immediately go back and do the revision as long as the soft tissues can be left alone. And I think no, I didn't. I'll keep going. I have a very liberal use of wound vacs. I essentially use them in all revisions with infections now. We've gone more and more towards this. Try to get the patient healthy. So during the second stage, try and get them healthy. You've got the IV antibiotics to eradicate the infections, monitor their inflammatory markers. It's been said many times before, they may not normalize, but we want to see a trend towards normal. Soft tissue and bony healing, nutritional supplement, increasing their hemoglobin. There are techniques for doing that. We always apply an antibiotic holiday. There's some debate as to what the length of the antibiotic holiday should be, but this paper from Antonia Chen demonstrated that a significant portion of their failures to eradicate infection occurred during that antibiotic holiday, just under 60%. So my conclusion is that this holiday helps to identify your infection control. The timing of reimplantation, not surprisingly, there is no real optimal time other than to say that there are no signs of concurrent or ongoing infection and the patient is medically optimized. At the second stage, again, a good redebridement, reculture. There's, I think, a very subjective nature to the frozen sections. You have to have a good pathologist. They'll often call you on the phone and say, well, what do you think? Which I don't think is very helpful. But if you've got a good pathologist and they can look at this, that can be a helpful step. And obviously the gross examination of the joint. Again, here's a mobile spacer. I don't think there's any question. This is before I did a replant. Then in this patient, that allows a quicker recovery in this appropriately selected patient. At the second stage, you want to do your best job just like you would at any other revision, standard versus aseptic revision with augments. Here's a case of a draining sinus I did with a mobile spacer. There's a spacer actually screwed in the femoral portion. I had to break the tibial dowels because he had an old fracture, and there he is. I think the video may or may not play. We'll skip the video. He's doing very well. Here's another lady who came into my office with a draining sinus. Again, last case of the day, as they always are, on a stretcher. I had to redebride, and I think this highlights another point that Dr. Gerger made, which is I was unable to obtain with my first massive resection a healthy bone and the distal femur, so I had to go back and do this a second time. And with my experience now, I would probably have been more aggressive the first time. So again, 2 points that highlight what he brought up earlier. And again, she's got a nice video. She's now 10 years out. She's doing very well. I actually just saw her on Tuesday. I revised her already. Not a small lady, as you can see from the soft tissue envelope. Cemented versus uncemented revisions, I think that's dealer's choice. Metal may be better than allograft in some of these cases. A single stage revision, we've all done it unintentionally. This is some data from the Mayo Clinic. They point out that leaving that spacer in, although 2/3 of them were medically unfit, did not have great outcomes. I would suggest to you what I took away from this was, if there's a potential that you're going to leave that spacer in, do a really nice job putting that spacer in, and you may have an equivalent or an appropriate result with it. Two-stage exchange, just published again out of Mayo, Rafa's shop this year. You can see there is not an insignificant failure rate down the road. Septic failures of 15% on the hip side, dislocation rate of 12%, and on the knee side, 7% aseptic failure, 11% two-year morbidity, so these are sick patients. This is the Mark Coventry Award. I do think there's some value in keeping people on antibiotics. We could perhaps debate this afterwards, but if you have an oral antibiotic after the second stage, there's an undetermined length of time, but I think there is a role. The single stage revision, I just present this from the two consensus back in 2013. 78% of delegates felt this was an appropriate step. It's now up to 93%. although in a recent European consensus, I think the majority of European surgeons were still doing a two-stage for most of their cases. This is one troubling study, and I think it makes me think twice about the single stage. This is from Antonia Chen again. They looked at whether if they had a positive culture at the time of the second stage revision, even one positive culture, their failure rate went from 21% up to 46%. So the very fact that there was any bacteria left in the wound significantly increased their failure rate long term. We still have work to do. The mortality rate is high. The infection, reinfection rates are pretty significant. And it's very difficult to, even with the Delphi consensus, determine what infection rate is and persistent infection with this. So in conclusion, I think this is a devastating complication. Two-stage revision remains the gold standard, at least where I work. And our efforts should really be directed, rather than debating, and I think we can, the single versus two-stage, really the topics of infection avoidance, patient outcomes, and infection eradication. We have a lot of work to do on these topics. Thanks very much.